All right, welcome to this rapid-fire explainer designed specifically to give chemotherapy-trained pharmacists the absolute highest-yield clinical pearls you need to master thyroid cancer for the BCOP exam. Look, we know your time is incredibly valuable, and the board exam expects you to know way more than just the basic guidelines. You need the granular pharmacotherapy details. So we're going to bypass all the fluff and get straight to the hard-hitting data you actually need to know.
Here's what we're tackling today: thyroid histology and genomics, a papillary thyroid carcinoma case, lenvatinib versus sorafenib pearls, a medullary thyroid carcinoma case, and we'll wrap up with advanced disease and prognosis.
Okay, let's jump right into Section 1, Thyroid Histology and Genomics. Let's map out the differentiated thyroid cancers, or DTCs. Think of this as your mental cheat sheet. First up, papillary thyroid carcinoma, or PTC. It's the most common DTC, and its genomic profile is just incredibly relevant for us. We see red fusions in about 7% of cases, RAS mutations in 13%, and a massive BRAF V600E or K mutation presence. Then we have follicular thyroid carcinoma, which is heavily driven by RAS mutations, seen in about 30 to 52% of cases. Finally, look down at oncocytic carcinoma. You might know it by its old name, Hürthle cell carcinoma. The absolute standout clinical pearl to remember here is that the majority of oncocytic carcinomas are non-iodine avid. That completely flips your management strategy on its head, because traditional radioactive iodine just isn't going to work for these patients.
Now, here is a highly testable number for you to lock in: 62%. A whopping 62% of papillary thyroid cancers harbor a BRAF V600E or V600K mutation. In the era of precision medicine, knowing that the vast majority of your PTC patients have this specific, targetable alteration heavily dictates your treatment pathway. It underscores exactly why broad genomic sequencing is an absolute mandate when you're dealing with advanced disease.
Moving right along to Section 2, let's look at a papillary thyroid carcinoma case.
Meet patient HT. She's a 54-year-old woman who initially self-palpated a right neck mass, had a total thyroidectomy, and her pathology confirmed a 5-centimeter papillary thyroid carcinoma. Crucially, 7 of her 33 resected lymph nodes were positive for disease. Next-generation sequencing shows she has that classic BRAF V600E mutation we literally just talked about. Fortunately, her staging shows zero evidence of distant metastatic disease. So take a second to really think about this. Based on these specific tumor characteristics, is she a candidate for observation? A multi-kinase inhibitor like lenvatinib? Maybe a BRAF-targeted combo? Or radioactive iodine?
To nail that answer, you actually need to know when not to treat. The NCCN criteria for observation are absolutely crucial here. You can safely observe a patient if their largest primary tumor is strictly less than 2 centimeters, if it's completely intrathyroidal with zero vascular invasion, and if they are clinically node negative. They also need undetectable anti-thyroglobulin antibodies, very low thyroglobulin levels, and a clean post-operative ultrasound. Let's look back at our patient, HT. She had a 5-centimeter tumor, way over that 2-centimeter cutoff, right? Plus, she had 7 positive lymph nodes. She completely blows past the observation criteria, so she definitely requires adjuvant intervention, specifically radioactive iodine, to clean up that microscopic residual disease in her lymph nodes.
All right, Section 3, lenvatinib versus sorafenib pearls.
Listen up, because this is a classic board exam trap regarding administration parameters. On one side, you've got lenvatinib. The dose is 24 milligrams taken once daily, and the massive pearl here is that it can be taken with or without food. It comes in 4 milligram and 10 milligram capsules, so the patient is actually taking a specific combo of pills to hit that 24 milligram mark. On the flip side is sorafenib. The dose is 400 milligrams using 200 milligram tablets, but it must be taken twice daily and strictly on an empty stomach. As a pharmacist, if you get a question about a patient with a tricky lifestyle, schedule constraints, or compliance issues, that with or without food versus empty stomach distinction, that is exactly what they are testing you on. Now, because these drugs hit similar receptors, including VEG, they share a pretty nasty overlapping adverse effect profile. As a clinical pharmacist, you absolutely must be prepared to counsel patients on these toxicities. We're talking significant hypertension, debilitating diarrhea, and hand-foot-skin reaction. You've also got to monitor for arthralgias, nausea, stomatitis, and notably, proteinuria. If your patient on lenvatinib or sorafenib comes into the clinic with a soaring blood pressure or intense blistering on their palms and soles, you need to know exactly how to hold, dose reduce, or supportively manage them right then and there.
Let's shift gears to Section 4, Time for medullary thyroid carcinoma case.
Meet patient KL. He's a 55-year-old man, status post-total thyroidectomy, and his pathology showed medullary thyroid carcinoma. He had a 2.2 centimeter primary lesion and multiple positive lymph nodes in his bilateral neck. He was on surveillance for about 3 years, but his calcitonin levels just kept creeping up, and imaging just confirmed new metastatic disease in his lungs. Now here is the absolute key piece of data. Both his germline and tumor next-generation sequencing came back completely negative for pathogenic RET alterations. Think about the targeted agents we have for metastatic medullary disease. How does a negative RET status completely flip your drug selection?
If you said cabozantinib, you nailed it. Now, if you were leaning towards a highly selective RET inhibitor like selpercatinib, well, you fell for the trap. Because KLL is explicitly negative for pathogenic RET alterations, those hyper-targeted RET inhibitors literally have no target to hit. They are completely off the table. This is exactly why you must confirm genomic targets before initiating therapy. Without that RET mutation, we have to rely on broader multi-kinase inhibition. That makes cabozantinib the standard of care and the best choice for managing his metastatic disease.
And finally, Section 5, Advanced Disease and Prognosis. Let's lock in some final, crucial pearls for advanced disease. You'll want to write these in stone for your exam prep. Number 1, traditional cytotoxic chemotherapy is usually not effective across thyroid cancer subtypes. It plays almost no role here, which is exactly why oral oncolytics and targeted therapies are the absolute cornerstone of systemic management. Number 2, medullary thyroid cancer originates from C cells, not follicular cells. That means it will never ever respond to radioactive iodine. Do not pick RAI for a medullary patient. And number 3, because our treatments are entirely dictated by the tumor's biology, broad genomic sequencing is absolutely mandatory to uncover actionable targets like BRAF, RET, and RAS.
To wrap up this explainer, we have to face a pretty harsh clinical reality. We've spent a lot of time talking about highly effective targeted agents, but anaplastic thyroid carcinoma sits at the absolute bottom of the prognostic hierarchy. It is incredibly aggressive, demands rapid, specialized, multidisciplinary intervention, and sadly still has very limited treatment options. It really leaves us with a massive question to ponder. With all the incredible advancements in targeted and immune therapies we're seeing at lightning speed in other cancers, how long will it be before we finally crack the code on anaplastic thyroid cancer? Or is it destined to remain the ultimate challenge in our oncology clinics? Definitely some food for thought. Keep studying hard, trust your clinical knowledge, and go crush the BCOP.